So imagine walking into a clinic because your sex life has become um, physically painful or perhaps just entirely numb, and the doctor sits down and tells you the cure isn't a synthetic pill or some daily hormone cream.
Right.
The cure is, well, it's currently flowing through your own vein.
Yeah, it's a profound shift really from the exogenous model of traditional medicine, where a pharmaceutical compound is put into you.
Right, like an outside fix.
Exactly. We're moving to an endogenous model where we are strictly relying on your own biological infrastructure to initiate a repair.
Which brings us to the core of today's deep dive. We are tearing into a pretty massive stack of clinical data to answer one highly specific question for you today. And that is, will sex actually feel better after the O shot?
That's the million-dollar question, isn't it?
It really is. And to figure this out, we are completely bypassing all the slick clinic marketing. We're looking strictly through the lens of functional regenerative medicine.
Yeah, we have to look at the actual science.
Exactly. So we've got a really fascinating stack of sources for you today. We're talking cutting-edge clinical trials from 2022 right up to 2026. Plus, we've got real-world protocols from private regenerative clinics in London and the official NHS guidelines on female genital procedures.
And our goal here is to map the actual biological mechanics of this, right?
Well,
Injecting your own concentrated blood plasma into your most sensitive anatomy.
right. Because before we can even touch the psychological or, the physical outcomes, we have to isolate those mechanics. We need to look at the actual biology of the O shot.
Yeah, because the cellular cascade that gets triggered by this procedure is incredibly dense. We are dealing with biological architecture here.
It's not just a surface-level aesthetic fix.
Not at all.
So based on the clinical protocols, the process starts simply enough, right? It's just a standard blood draw from the arm.
Yeah, just like getting routine labs done.
But then that blood is placed into an FDA-approved centrifuge.
Yeah.
Our sources mention systems like the Regenator or Golden VC, and they spin it at around 3,000 RPM for 10 minutes.
Right, because blood is fundamentally a suspension. The centrifugal force is deployed to basically break that suspension apart based on density.
Okay, so the heavier stuff sinks.
Exactly. The heavy red and white blood cells are forced down to the bottom, and that leaves this golden, sort of straw-colored liquid suspended at the top.
And that's the PRP.
That is platelet-rich plasma, or PRP, yes.
And the defining metric here, the thing that makes it work, is the concentration. The clinic data notes they are isolating over 1 million platelets per microliter.
It's a massive concentration.
Yeah. So instead of looking at this like an espresso double shot of energy for your cells, a better analogy might actually be a construction site.
I like that analogy.
Right. Because you aren't just giving the existing cells energy. You are taking this hyper-concentrated PRP, activating it with calcium chloride, and basically dropping a massive team of specialized foremen onto an abandoned construction site.
That is the exact mechanism. Under normal physiological conditions, your platelets just circulate quietly. They're acting as sentinels, just waiting for tissue damage.
Like a smoke detector.
Yeah, perfectly said. And when they are forcefully activated and injected into the targeted mucosal tissue, so the clitoris or anterior vaginal wall, they degranulate.
So by degranulating, I mean they're essentially bursting open, right?
Yes. They burst open and completely flood the local tissue with these heavy-hitting proteins.
The sources mention VEGF, so vascular endothelial growth factor, and EGF.
Right.
So these foremen are basically screaming at the local stem cells to wake up and start building scaffolding and plumbing.
They are acting as highly specific chemical messengers. VEGF, for instance, specifically dictates neoangiogenesis.
Which means making new blood vessels.
Exactly. It forces local stem cells to differentiate into endothelial cells, literally mapping out and constructing entirely new microscopic blood vessel networks within the tissue.
Wow.
And simultaneously, other growth factors are stimulating fibroblasts to synthesize fresh collagen for structural integrity. And crucially, they're promoting the regeneration of peripheral nerve endings.
Okay, think about the weight of this for a second if you're listening. You aren't masking a symptom here.
No, you're not.
You are leveraging your body's own architectural blueprint to force the growth of new neural and vascular infrastructure.
In tissue that may have severely degraded.
Right, due to trauma or, estrogen drops during menopause or just chronic inflammation.
You are quite literally attempting to reverse the physiological clock of the tissue.
So the biological blueprint is sound. The theory makes total sense. But forcing stem cells to build new capillaries under a microscope is one thing.
Translating that into measurable human pleasure is a completely different story.
Exactly. When we look at how this maps onto real women experiencing severe sexual dysfunction, the clinical data is intense.
Yeah, the 2022 study published in Gynecologia I Polosnik 2 provides a really clear window into this translation.
Right, they tracked 30 women who were clinically diagnosed with female sexual dysfunction, or FSD.
And they used the Female Sexual Function Index to track them.
The FSFI. For context for you guys, this is a 36-point scale. Anything under 26.5 is the clinical threshold for dysfunction.
Right.
And these 30 women started with a mean baseline score of 16.50, so very low. But 4 months post-PRP injection, that mean score jumped to 28.50.
Which is huge.
Yeah, they moved entirely out of the dysfunction category
Yeah.
and into a healthy baseline. The data shows broad improvements across, like desire, arousal, lubrication, and orgasm.
It's a remarkably comprehensive improvement.
But, and here's where I want to push back a little bit, I am looking at the specific domain for pain in this study, and there is a glaring anomaly.
Ah, yes, the pain domain.
The p-value for the pain domain is 0.085, so it didn't hit statistical significance. If the PRP is actively rebuilding the plumbing and the wiring of the tissue, why are these women still experiencing painful intercourse?
Well, this exposes the absolute physical limitations of mucosal regenerative medicine. We really have to separate mucosal surface health from deep pelvic pathology.
Okay, break that down for us.
So PRP is highly effective at increasing superficial vascular density, right?
Yeah.
Which floods the tissue with natural lubrication and heightens clitoral nerve sensitivity.
So it makes the arousal arc faster and orgasms more intense?
Yes. But it's not penetrating deep enough to fix structural mechanics.
Okay.
It just cannot. Dyspareunia, or painful intercourse, is frequently driven by deep mechanical issues. A patient might have severe endometriosis pulling on the pelvic organs,
Oh, wow.
or hypertonic pelvic floor muscles that are physically spasming during penetration, or even deep surgical scar tissue.
Right, so injecting growth factors into the anterior vaginal wall isn't going to, relax a spasming muscle deeper inside.
Exactly. The mucosal surface is much healthier, but the underlying mechanical collision is still occurring.
Which means PRP is absolutely not a blanket cure for all pelvic pain.
No, it's not.
Yet, despite the pain scores not significantly dropping, the psychological shift in this exact same group of women was massive.
It was.
The researchers tracked the Female Sexual Distress Scale, the FSDSR. And the women's scores dropped from 19.33 down to 10.63.
Which is a profound drop.
Yeah. They explicitly note that 83% of the women who started in the distressed category moved to not distressed.
Right.
So it seems like even if the physical discomfort wasn't entirely erased, the anxiety, the profound frustration, and just the psychological weight surrounding their sex lives essentially evaporated.
Yeah, the uncoupling of physical sensation and psychological distress is a vital clinical outcome here. When arousal becomes easier to achieve and orgasm is more accessible, the overall sexual encounter shifts.
It shifts from a source of absolute dread.
Exactly. It becomes manageable or even enjoyable, despite some lingering structural discomfort. Reclaiming that agency drastically reduces the distress metric.
This brings up a fundamental tension, though, because rebuilding tissue, letting those, biological foremen synthesize new collagen and capillaries, that takes months.
It's a slow biological process.
And human nature is inherently impatient. If the goal is to increase physical sensation and friction, how does this slow biological marathon compare to an instant mechanical fix?
Well, the whole field of intimate injectables has practically fractured over this exact question.
Right. Because we have a brand new 2026 pilot study in our stack, published in JSM Sexual Medicine, and it addresses this rivalry directly.
It's a brilliant study design.
They set up a head-to-head trial pitting the O-Shots PRP against cross-linked hyaluronic acid.
Often referred to as the G-shot.
Yes. We see hyaluronic acid, or HA, used constantly for facial volume and joint lubrication. But here it's injected directly into the anterior vaginal wall to augment the G-spot area.
And the results were fascinating.
The data completely flipped my assumptions. At the 3-month mark, the hyaluronic acid group reported a 68.1% improvement in their total FSFI scores.
While the PRP group only saw a 45.7% improvement.
Right. So on paper, the inert dermal filler thoroughly beat the body's own regenerative plasma.
Well, we are looking at the difference between mechanical volume and biological repair. Hyaluronic acid does not regenerate tissue at all.
It's just a filler.
Exactly. It is a highly viscous hydrophilic gel. When it's injected into the anterior vaginal wall, it immediately occupies space, creating a pronounced physical bulge in the mucosa.
So it's essentially acting as a permanent shock absorber, or structural scaffolding.
Right. And during intercourse, that immediate volumetric enhancement drastically alters the friction dynamics.
Because it's pushing the tissue outward.
Yes. Meaning the underlying mechanoreceptors, the nerves that respond to physical pressure, are being stimulated much faster and with significantly less effort.
So the physical reality of the anatomy is altered from the minute the patient leaves the clinic.
The friction is amplified instantly. PRP, conversely, provides almost zero mechanical volume.
Really? None?
Practically none. The plasma fluid itself is rapidly absorbed by the body within days.
Oh, wow. Okay.
All that is left behind are the microscopic platelets binding to receptors, signaling the stem cells to begin that slow process of cellular turnover.
So the filler is a sprint. It's an immediate structural modification of the physical space.
Yes.
But the PRP is a marathon. It is fundamentally changing the biological health of the tissue, but at 3 months, it's literally still in the middle of construction.
Which is why the clinical debate centers on the trajectory of those results. Hyaluronic acid is eventually degraded and metabolized by the body's natural hyaluronidase enzymes.
So the mechanical volume will invariably disappear.
It has to, yes. The long-term question is whether the neoangiogenesis and nerve regeneration triggered by the PRP will ultimately outlast the lifespan of the synthetic filler.
Oh, I see.
The 3-month data clearly favors volume, but tissue health is a much longer curve.
Now, there is a catch to this regenerative marathon, though, and it completely shifts how we have to conceptualize this whole treatment.
Oh, absolutely.
Because we've established that PRP regenerates tissue and improves sexual function. But another study in our stack exposes a pretty profound limitation on how these stem cells actually communicate.
You're referring to the Keough study on stress urinary incontinence.
Yes, the SUI study. They took a cohort of women suffering from SUI, so leaking urine during physical exertion, or coughing, sneezing.
Which is incredibly common.
Very. And they injected these women with PRP. The functional results for their daily lives were excellent. Their objective daily pad test leakage dropped from an average of 5.35 grams down to 2.55 grams.
Having the leakage volume is a massive restoration of daily quality of life.
It's totally life-changing. But the researchers also ran the exact same FSFI sexual function questionnaire on these incontinence patients.
Right.
And the women reported practically zero improvement in their sex lives.
It's a fascinating paradox.
Their mean scores went from 17.9 to 20.3. Statistically, that's a flat line. They're still clinically dysfunctional.
Yeah.
So my question is, if PRP is this potent biological trigger for neoangiogenesis and nerve sensitivity, why didn't it help these women in the bedroom?
This is where we uncover the reality of hyperlocalized cellular communication. When we talk about growth factors signaling stem cells, we really have to recognize that this communication is physically trapped by the extracellular matrix.
Trapped.
Yes. The growth factors do not migrate. They bind to receptors precisely where they are deposited.
So in the SUI study, the doctors were targeting a mechanical failure of the bladder.
Exactly. They injected the PRP deep into the tissue immediately surrounding the external urethral sphincter to rebuild the collagen in that specific muscular ring.
And the biological cascade was entirely restricted to the sphincter.
Right. The local stem cells reinforced the urethra, which reduced the urine leakage, but the injection was nowhere near the clitoral nerve complex or the highly innervated anterior vaginal wall.
So the precision is absolute. The stem cells in the clitoris literally had no idea the PRP was even in the body, because the chemical messengers just didn't travel those few centimeters across the pelvic floor.
That's exactly it. When doctors perform the O shot specifically for sexual dysfunction, they have a completely different anatomical map.
Okay, where are they aiming then?
They are injecting the clitoral hood, the bilateral crura, and the submucosa of the vaginal wall.
Wow, so the biological response is strictly bounded by the physical spread of the plasma.
Yes, the body only rebuilds the exact millimeter of tissue that receives the platelet signal. The needle placement dictates the entire functional outcome.
It really elevates the procedure from a simple injection to a highly demanding anatomical exercise, doesn't it?
It requires extreme precision, yes.
And given how hyperspecific and powerful this biology is, it's fascinating to look at how the broader medical establishment views procedures in this region.
Yeah, there's quite a contrast there.
Right, because we have this explosion of private clinic innovation, But the National Healthcare Guidelines tell a very different story.
The official stance provides a necessary boundary, though, against the commercialization of female anatomy.
Absolutely. If we look at the Right Decisions NHS Scotland guidelines, they have a definitive, deeply cautious stance on female genital cosmetic surgery, or FGCS.
Right.
This encompasses procedures like labiaplasty, where tissue is surgically removed, or hymenal reconstruction. The NHS classifies these as medically non-essential.
And rightfully so.
But more than that, their documentation actively warns clinicians about the immense societal pressure women are under. Pressure to conform to this idealized, almost prepubescent aesthetic standard for the vulva.
The guidelines are prioritizing risk avoidance. The NHS highlights that these surgical procedures carry severe complication profiles.
Yeah, reading through the risks was pretty sobering.
They document risks of permanent altered sensation, dense scar tissue formation, and a wound dehiscence rate approaching 30%.
And dehiscence is where the surgical incision physically bursts open after the operation, right?
Yes.
A 30% dehiscence rate is staggering for an elective cosmetic procedure.
It's incredibly high.
So this made me wonder, does the O-shot, which is heavily marketed by private aesthetic clinics, fall into this same category? Like, is this just another manifestation of societal pressure pushing women to alter their genitals?
Well, the medical reality demands we separate aesthetic modification from functional regeneration.
Okay, how so?
The NHS is categorically warning against surgical tissue removal designed to alter the external visual appearance of the anatomy. The O-shot does not alter the visual shape or size of the external labia at all.
Oh, I see. It does not conform to an aesthetic trend.
No, it is entirely invisible from the outside.
The focus is purely internal tissue health.
Exactly. If we look at the clinical protocols from Elite Aesthetics, one of their primary applications for PRP isn't even sexual enhancement.
Right.
It's the treatment of lichen sclerosus.
Which is an aggressively cruel condition.
It really is.
For those who might not know, it's a chronic autoimmune disorder that attacks the vulvar tissue. It causes microscopic tearing, severe pain, and eventually it basically fuses the structural tissue together.
And the baseline medical treatment is heavy, continuous application of topical corticosteroids.
Which inherently thin and degrade the skin over long-term use.
Right. Patients become trapped in this terrible cycle of managing the inflammation, while the steroids slowly compromise their tissue integrity even further.
So private clinics are utilizing the regenerative power of the O-shot to force the growth of robust, healthy tissue in these patients.
Yes. Physically reinforcing the mucosa to withstand the tearing and drastically reducing their reliance on the topical steroids.
It's the stark difference between cosmetic surgery and functional medicine.
Very much so.
The NHS is guarding against the unnecessary removal of tissue for beauty standards, whereas regenerative medicine is actively attempting to rebuild degraded tissue so a patient can live painlessly.
Right. To manage autoimmune conditions and maintain a functional sex life. The intent of the intervention visual conformity versus biological function is the dividing line.
So, tracing the complete architecture of this deep dive, we start with a simple blood draw. But by running that through a centrifuge, we isolate the biological foramen, the platelets.
Yes.
And when those are precisely deployed into the specific millimeter of degraded tissue, they force a micro-localized cascade of neoangiogenesis and nerve regeneration.
And the clinical evidence confirms that this biological marathon translates into significant, measurable increases in physical arousal and a profound drop in psychological distress.
Even if it cannot mechanically alter deep pelvic pathology.
Right. It's not a miracle cure for everything.
And while a synthetic hyaluronic acid filler might offer a faster mechanical structural boost by physically plumping the tissue, the PRP is fundamentally attempting to reverse the biological clock of the mucosa itself.
It is a vital, non-hormonal, non-surgical tool.
And the context for why this is so critical just cannot be ignored. Current data suggests up to 40% of women suffer from some form of sexual dysfunction.
It is an epidemic of silent suffering, largely dismissed by traditional avenues as just a natural consequence of aging, childbirth, or menopause.
Millions of women are essentially told to just accept a sudden, drastic reduction in their quality of life.
Exactly.
But the cellular mechanics we've mapped out today prove that biological degradation does not have to be a permanent sentence.
Which leaves us with a necessary question to consider.
What's that?
Well, if the human body inherently possesses the concentrated cellular blueprints to literally regenerate its own vascular networks and nerve endings, to rebuild its own capacity for pleasure, how much of sexual aging or dysfunction is truly an inevitable decline,
Wow.
and how much is simply a biological waiting game for the right regenerative key to unlock the architecture that is already there.